So let us make sure that you know the most difficult part of anatomy today, and that is the skull. You start looking at the skull from inside after you have removed the topmost portion of the skull and you are peeping from the superior aspect and seeing the three cranial fossas in the skull. So that is called as basis cranii interna, and the three cranial fossas are actually three steps which are progressively deeper. The anterior one, then the middle one, and then the posterior one. Let us learn the basis cranii interna today. So here you have the outer table of the skull. It's like this. And on the posterior side, you have a protuberance called the external occipital protuberance. Then the inner table has got a crest like this, which is called as the frontal crest. And then it goes around parallel to this, forming an internal occipital protuberance here. And this is what we have made the internal table. You have removed the calvaria, you have removed the upper part of the skull, and you are looking inside. So the first thing you must draw is this wing type of structure with two processes like this, and this is the free edge of the lesser wing of sphenoid. Okay. Now, if you make the lesser wing, you will find the wing like this, and it projects like this, and this projection is called as jugum sphenoidale. Behind the jugum sphenoidale, you have a projection which is called as the tuberculum sali. Anterior to this, you have a crest which is called as crista geli, because the fox cerebri is attached to it. Between the crest, you have a foramen-like structure. Between the frontal crest and the crista geli, you have a foramen. This will make the foramen blue. So you have this foramen-like structure, which is the foramen cecum. Around the crista geli, you have a plate which has got multiple holes in it, and this plate is called as cribriform plate. Lateral to the cribriform plate and covering its lateral part is the orbital plate of the frontal bone. You see, the frontal bone comes like this, and then it gives a portion which is the frontal plate of the orbital plate of the frontal bone, and there's the maxilla below, and this is the orbit. So this is the anterior cranial fossa, This is the orbit, and this orbital plate, this one, divides the anterocranial fossa and the orbit. Now, when this orbital plate comes near the cribriform plate, so here is the cribriform plate, here is the crista galli, and there are two boxes hanging from it. And here is the frontal orbital plate of the frontal bone. So here you will be the anterocranial fossa, here you will have the orbit, and here you will have the nose. And this is the ethmoid bone with two boxes hanging from the cribriform plate containing the ethmoidal air sinuses. So now there's a nasociliary nerve here, and that nasociliary nerve gives a branch which passes through these ethmoidal foramen and then through the cribriform plate into the nose, into the mucosa of the nose. So this nasociliary nerve passes through foramen between the orbital plate of the frontal bone. This is the orbital plate of the frontal bone, and the cribriform plate of the ethmoid. And these foramen we will now place here. So there is the anterior foramen, anterior ethmoidal foramen, and posterior ethmoidal foramen, passing the nerve from the nasociliary branch of the ophthalmic nerve into the anterocranial fossa, and then from the anterocranial fossa through the cribriform plate into the nose. After that, in the anterocranial fossa, you have to remember that there are impressions created by the gyri and sulci of the frontal lobe of the brain. So these structures finish the anterior cranial fossa. Now we'll go to the middle cranial fossa. Frontal crest, internal plate, internal occipital protuberance, and this is the anterocranial fossa that we have made. The foramen cecum, the crista galli, the cribriform plate, the frontal eminence. We have made the jugum sphenoidale here, and the lesser wing of sphenoid, and the tuberculum sali. So just posterior to this, on the medial side of the anterior clinoid processes, is the optic foramen, passing the ophthalmic, passing the optic nerve. Optic foramen, optic nerve. Lateral to the anteroclinoid process is a superior orbital fissure. Again, from the middle cranial fossa, it is going into the orbit, and the superior orbital fissure passes the third, the fourth, the fifth A, and the sixth nerve. Fifth A means there are three branches of the fifth: A, B, and C. A is ophthalmic, B is maxillary, and C is mandibular. So it's the fifth A, the ophthalmic branch which passes through this. Supraorbital fissure passes the third, fourth, fifth, and sixth nerve. The superior and inferior ophthalmic veins and the lacrimal branch of meningeal artery and meningeal branch of lacrimal artery. So this is how you remember what passes through the supraorbital fissure and the optic foramen. So this is the optic foramen on this side, this is the supraorbital fissure. The point that the lesser wing meets this inner plate, point corresponding to it on the outer plate is called as pterion. The importance of pterion is that the middle meningeal artery, which is an extradural artery, which is outside the dura, lies on the pterion, and when it ruptures, it can cause a hematoma, extradural hematoma in this extradural hematoma, which can press the brain. So this is pterion and this is the middle meningeal artery relation to it. So when you want to approach the middle meningeal artery, you approach through the pterion. Now we'll make the petrous temporal bone. We'll make a notch here and the posterior clinoid process. Again the posterior clinoid process, again a notch, and we'll place the petrous temporal bone like this. Now, in the middle part of the middle cranial fossa is called as sella turcica. In front it has got a tuberculum sali. Then behind it is the hollow space in which lies the pituitary gland, which is called as sella turcica. And behind it you have a projection which is called as dorsum sali. If we want to draw it, it is something like this. Tuberculum sali, jugum sphenoidal, tuberculum sali, sella turcica and dorsum sali. And this is the sphenoidal sinus, and all this is lying in the base of the brain. So this is the sphenoidal air sinus. This is the jugum sphenoidal, and that beak that you see there, then the tuberculum sali, then the sella turcica and the dorsum sali. There is a membrane which covers the starts from the anterior and posterior clinoid process and separates the space, and this membrane is called as diaphragma sali. The pituitary gland is connected to the hypothalamus by the hypophysis, and the pituitary gland lies here. So here is the hypothalamus and this is the pituitary, which is the master gland of the body. So so if you see the diaphragma sali from above, you will find that the diaphragma sali looks like this. From the anterior and posterior clinoid process, all this is dot, and here is a hole through which the hypophysis of the pituitary is passing. Now just lateral to this dorsum sali lies a sinus, a venous sinus, which is called as cavernous sinus. Cavernous sinus. If we want to make the cavernous sinus, see a section of it, Then this is the sala turcica, and here is the sphenoidal sinus, and here is the diaphragma celli, and here you see the pituitary like this, and on the side of the body of sphenoid you see this cavernous sinus. Now, inside this cavernous sinus lies the internal carotid artery. If we trace, if we look at the side of the sphenoid, then there is a foramen lacerum here, and this is the posterior clinoid process, and you are seeing the sala turcica, the tuberculum celli, and the dorsum celli. And here we are seeing the cavernous sinus. This is the cavernous sinus. So the internal carotid artery lying in the carotid canal outside the skull enters through the foramen lacerum, enters the cavernous sinus, and becomes the anterior cerebral and the middle cerebral artery. So one important content of the cavernous sinus is the internal carotid artery. Now, if this artery ruptures into the cavernous sinus, there is what is called as a carotico-cavernous fistula. So you can hear the blood, as the blood passes through that carotico-cavernous fistula, you can have two physical signs. If you put your stetho on the eyeball, you may be able to hear a bruit, a sound through the stethoscope, which indicates arterial blood passing into the vein through a fistula. The second thing is that the arterial pulsations are conveyed through the superior and inferior ophthalmic veins, which are connected to the cavernous sinus, into the eye, and therefore the eye starts pulsating inside and outside with the pulsation of the artery, with arterial pulsation. That is called as pulsating exophthalmos. So a bruit and a pulsating exophthalmos on hearing on the artery indicates a carotico-cavernous fistula. Now, there is a nerve which arises from the pons here. You place this nerve here. It emerges from the brain at this point, goes up, goes across this notch, is bounded by a ligament. Ligament covers this notch in the petrous bone. This ligament is known as ligament of Guber. And this nerve is the sixth or the abducent nerve. Now this, we have placed the artery in the medialmost portion, and this nerve is lying just lateral to the artery, passes through the supraorbital fissure and supplies the lateral rectus of the orbit, the lateral rectus of the eyeball. So here is your eyeball. So what happens is that when there is a lot of pressure, there is a membrane here. So this is a membrane like this. This is a part of the dura, and there's a notch, and through this notch is passing the brainstem. Now, if there is a lesion above this, this is called as tentorium cerebelli. So if there is a lesion above the tentorium cerebelli, the tentorium cerebelli will be pressed down, and the brain stem will be pressed down, and the sixth nerve will get stretched over this bend as it enters the petros as it goes under the petrosphenoid ligament of Goober. It gets stretched here, and this bend is called as the bend of Wolf. So we have named the bend of Wolf. We have named the petrosphenoid ligament of Goober. Petrosphenoid ligament of Goober, and this nerve, when it passes up on this bone, lies in a sinus which is called as the inferior petrosal sinus. So there is a superior petrosal sinus above here, there is the inferior petrosal sinus, and there is a sigmoid sinus which comes like this and goes into the internal jugular foramen to become the internal jugular vein. Now this inferior petrosal sinus connects to the sigmoid sinus, this is sigmoid S type sinus, and becomes the internal jugular vein. So when this nerve is lying in the vein, this is called as the canal of Durella. So bend of Wolf, petrosphenoid ligament of Goober, the sixth nerve passing through the canal of Durella, having a bend of Wolf where it is stretched and can get paralyzed if there is a supratentorial space occupying lesion. A space occupying lesion, a hematoma, a tumor above the tentorium cerebelli. So this bend of Wolf, and as it gets stretched here, it is the lateral rectus which can get paralyzed. Now if the patient is unconscious, supposing you are looking from above, and here is one eye and here is the other eye, and this is the lateral rectus of this side, the medial rectus of this side. So if this lateral rectus is paralyzed and you turn this patient in this, turn the head in this, the eyes to fix, this eye to fix will move medially, but this will not be able to move laterally. So you will have a picture of this eye pointing this side, but this eye fixing. So this will indicate the lateral rectus paralysis in an unconscious patient, and this type of to and fro movement, right and left movement, is called as doll's eye movement. So we have, through the cavernous sinus, we have again placed one nerve, which is the abduced nerve. And then on the lateral wall of the cavernous sinus, there lie four nerves, 1, 2, 3 and 4, and this we remember by OTOM. Oculomotor, trochlear, ophthalmic, maxillary. All right. So, oculomotor is the third. This is the fourth. This is the fifth A. And abducent is the sixth. I have told you the superior orbital fissure passes the third, fourth, fifth A, sixth nerve. Now, the fifth B division, A passes through the superior orbital fissure. Fifth B division passes through another foramen which is called as foramen rotundum. Then you have a foramen which is called as foramen ovale. Now what passes through ovale? Male passes through ovale. Fifth B has passed, maxillary has passed. So mandibular nerve, accessory meningeal artery, accessory, lesser superficial petrosal nerve, and imagery vein. Male passes through foramen ovale. All right. Now, in this, the most important thing is the lesser superficial petrosal nerve. That lesser superficial petrosal nerve, then there is another foramen behind, just behind this, which is foramen spinosum. Foramen spinosum. The middle meningeal artery, which cause the extradural hemorrhage and can be approached through the pterion, enters through foramen spinosum. So the artery enters through foramen spinosum. So after you have cleared the hematoma, if you put in a bone wax or spike in the foramen spinosum, the artery will no longer bleed. Okay. Now, foramen rotundum, supraorbital fissure, foramen rotundum, foramen ovale, foramen spinosum. And now we go on to this component, the last component, where there is a triangular area here, sloping triangular area here, and a sloping triangular area medial. So lateral and medial sloping triangular area. The lateral area is called as tegmen tympani. The tegmen tympani separates the mastoid air cells so here is the skull, here are the mastoid air cells, and the tegmen tympani is roofing the mastoid air cells. So when there is pus collection in the mastoid air cells in chronic suppurative otitis media, then this pus can go through the tegmen tympani and reach the middle cranial fossa and affect the temporal lobe of the brain. So this is the importance of this tegmen tympani. Tegment tympani. It is involved in osteomyelitis and it can cause a temporal lobe abscess. Then the last foramen here is the foramen lacerum, through which enters the internal carotid artery, having a F-shaped course and ending in the anterior cerebral and the middle cerebral artery. The medial slope of the petrous temporal bone. We'll enlarge this area, okay? So this is the petrous temporal bone. All right. And we have made the tegment tympani here. And we have another triangular area medial to it. This is the petrosphenoid ligament of Guber. Here you have the inferior petrosal sinus entering the cavernous sinus, and in it is containing the abducent nerve which is bending around this petrous bone. So this is what is called as the trigeminal impression. So this is the tegment tympani and this is the trigeminal or the trigeminal impression. The area that contains the congruence of the fifth nerve. The area that contains the fifth nerve, and it is dividing into three: ophthalmic, maxillary and mandibular. So this is the area which contains the trigeminal ganglion. This is called as ganglion. And from under this there are two hiatus, two small openings through which arise the lesser superficial petrosal nerve. Now this lesser superficial petrosal nerve passes through the foramen ovale, merges with the mandibular, goes into the auriculotemporal, and supplies the parotid gland. The greater superficial petrosal nerve goes into the foramen lacerum. Entering through the foramen lacerum is the internal carotid artery. Around it is the sympathetic plexus. So with the sympathetic plexus, the greater superficial petrosal nerve, now this is the greater superficial petrosal nerve with the sympathetic fibers from around the internal carotid artery, becomes the deep petrosal nerve. It passes through the bony canal. So what happens is that we'll make this diagram for you to be able to understand. This is the styloid, this is the mastoid. Here you have the temporomandibular fossa, the zygomatic, the orbit. Here is the nose. Here is the posterior part of the maxilla, and here you see the lateral plate of the lateral pterygoid plate. The medial pterygoid plate is medial. So this nerve, here is somewhere here is the foramen lacerum. So the internal carotid artery enters the carotid canal, then passes like this and then enters through the foramen lacerum. Now this nerve emerges out of the foramen, greater superficial petrosal nerve emerges out of the hiatus for the greater superficial petrosal nerve, then out of the foramen lacerum, combines with the sympathetic plexus around the internal carotid artery and passes through a canal into the pterygomaxillary fissure. Now this is called as the Vedian nerve or the deep petrosal nerve. All are related to the petrous bone, so deep petrosal nerve. From this, it hikes onto the maxillary nerve, from maxillary to the ophthalmic, the lacrimal branch of the ophthalmic, and supplies the lacrimal gland. So greater superficial petrosal nerve arising from the geniculate ganglion of the seventh passes through the hiatus for the greater superficial petrosal nerve, then lies under the trigeminal ganglion, the impression for the trigeminal ganglion, then into the foramen lacerum, then combines with takes sympathetic branches from around the internal carotid artery, then becomes the deep petrosal nerve, then hikes onto the maxillary, from maxillary through its zygomaticotemporal branches onto the lacrimal branch of ophthalmic and supplies the lacrimal gland. I think we have covered all the nuances of the middle cranial fossa by now. And I think we will revise them in the next go, and we'll cover the posterior cranial fossa now, and that is that we have already made we've made the anterior cranial fossa, crista galli, the foramen cecum, the cribriform plate, the anterior and posterior ethmoidal foramen, the H-shaped impressions of the frontal lobe, the jugum sphenoidale, the tuberculum sali, the optic foramen, the superior orbital fissure. Then we have made the posterior clinoid processes, placed the petrosphenoid ligament of Guber, and we have placed foramen, we have placed tuberculum sali, sala turcica, dorsum sali, and we have placed the cavernous sinus lateral to it, and through the cavernous sinus we have passed the internal carotid artery coming from the foramen lacerum and becoming the anterior cerebral and middle cerebral. The sixth nerve We passed the sixth nerve through the canal of Dorilla, bend of Wolf, going through the supraorbital fissure, supplying the lateral rectus, which takes the eye outside. Then we have placed the O-tom, oculomotor trochlea ophthalmic maxillary. So the ophthalmic and maxillary, for ophthalmic and maxillary we've made the foramen rotundum, foramen ovale. What passes through foramen ovale? Mandibular nerve, accessory meningeal artery, lesser superficial petrosal nerve, and imagery vein. Now, with the lesser superficial petrosal nerve, we know that it comes from the geniculate ganglion of the facial nerve, which is lying inside the internal acoustic meatus, and it goes out of the foramen ovale through the mandibular nerve and supplies the parotid gland. The greater superficial petrosal nerve arises from the hiatus for the greater superficial petrosal nerve under the trigeminal impression, goes through the foramen lacerum, becomes the deep petrosal nerve or the Vidian nerve, hikes onto the maxillary, hikes onto the lacrimal branch of the ophthalmic and supplies the lacrimal. You made this much. Same way we made a tegment tympani. We have said there is a foramen spinosum, and we made a tegment tympani, and we have said that when this is involved in chronic suppurative otitis media, it can cause a temporal lobe abscess. Then the posterior cranial fossa, this is the foramen magnum. These are the occipital condyles which articulate with the first atlas vertebra. So these are the balls and the atlas is the socket. Then you have two foramen, anterior and posterior hypoglossal foramen. Hypoglossal because the 12th nerve is called as hypoglossal, and the 12th nerve passes through the hypoglossal foramen. Then we make the jugular foramen, divide it into three. The sigmoid sinus turns around and enters the posterior part of it. The inferior petrosal sinus enters the anterior part of it, and this is containing the abducent nerve to some extent, upper extent of it. And then there are the three nerves in between, the 9th, 10th and 11th. So 9th, 10th and 11th nerves. Sigmoid sinus becoming, with the inferior petrosal sinus becoming the internal jugular vein. Then we have a foramen which enters, through which enter this is the internal acoustic meatus. Internal acoustic meatus, and through the internal acoustic meatus enters the 7th nerve. Its nervus intermedius component, which forms the geniculate ganglion and gives the lesser and greater superficial petrosal nerves. Then the 8th nerve, which is the vestibulocochlear, the anterior inferior cerebellar artery, and a ductus endolymphaticus, which supplies the fluid to the vestibule of the internal ear. So if this is blocked, there is raise in pressure in the internal ear, and you can have what is called as benign positional vertigo. So the 10th nerve, which is emerging here, also gives a branch near the ear in the around the mastoid process. So if you put cold water on the mastoid process, the 10th nerve is stimulated and you can produce a vomiting. So since rich Greek people called aldermen used to go into multiple dinners, so they used to go into one dinner, then produce a vomit by trickling cold water on the mastoid, and then go to another party. And therefore, this nerve connecting the 10th nerve to the mastoid skin on the mastoid process behind the ear is called as Alderman's nerve. So this finishes the basis craniae interna. Let us start recording the internal basis craniae interna or skull from inside on this real photograph of the skull. So this was the calvaria. This was the calvaria, and this was the frontal bone. Okay, and you can see the inner and the outer table of the calvaria going right up, right back, and you can see the external occipital protuberance here. Then there was this frontal crest. On which was attached the falx cerebri. Then this foramen that you see here is the foramen cecum. We'll rub off this so that you can see it. Okay, so that's the foramen cecum. Then we see the crista galli, attachment of falx cerebri, but that crest is the projection of the nasal septum into the anterior cranial fossa, and that comes through this cribriform plate. Then you have these two foramen between the orbital portion of the frontal bone. This is the orbital plate of the frontal bone. And you see these two foramen opening up here, and these are the anterior and posterior ethmoidal foramen. The nasociliary nerve, the ophthalmic branch of the nasociliary, lies in the orbit. Ophthalmic branch of the nasociliary nerve lies in the orbit. Between the orbit and the cribriform plate, it emerges into the anterior cranial fossa. Then through the cribriform plate, it goes into the nose. So that was the course of that nerve. Very complex, but very simple. Then you see that behind this orbital plate of the frontal bone is this wing-shaped structure. And this wing-shaped structure is the lesser wing of sphenoid. It is attached to the calvaria at this point, which is called as the pterion. Then this wing-shaped structure has a beak-like projection, which is called as the jugum sphenoidale. We'll take another color here. Behind the jugum, this wing-shaped structure ends into processes which are called as anterior clinoid process. Medial to the processes is the optic foramen. This one, which passes the optic nerve. Then you have this projection like this, which is called as tuberculum sali, because it's a tubercle. Then you have a concavity, which is here, which houses the pituitary gland, the sella turcica. Then you have this projection going from the foramen magnum and forming a saddle-like backrest onto the sella turcica, which we call as the dorsum sali. And the dorsum sali ends in the posterior clinoid processes. Connecting the anterior and posterior clinoid processes is a membrane like this, which is called as diaphragma sali. And this diaphragma sali has got a hole in between it, from which the hypophysis of the pituitary gland, which is lying in the sella turcica, connects to the hypothalamus, which is called as the hypophysis cerebri. So this is the structure in the middle of the middle cranial fossa. Lateral to the middle cranial fossa, you have the cavernous sinuses here. The main structure that passes through the cavernous sinus enters through the foramen lacerum, the internal carotid artery, and winds like this into the anterior cerebral and the middle cerebral. So this is the internal carotid artery. Then the nerves that lie in the cavernous sinus. One of the important nerves is the sixth nerve, which arises in this, lying in the inferior petrosal sinus, bends round under a ligament. So this nerve bends down under this ligament, the petrosphenoid ligament of Guber, lies lateral to the artery, enters the superior orbital fissure, and supplies the lateral rectus muscle, which is under the orbital plate. So this bend can cause it the bend of wolf. This is the canal of Dorilla, this is the bend of wolf, and this bend of wolf can cause this nerve to get compressed here, and the lateral rectus gets paralyzed whenever there is a lesion which is supratentorial, above the tentorium cerebelli. So we'll draw the attachment of the tentorium cerebelli here. We'll get a much deeper green color for the tentorium cerebelli. So this is one attachment, the petrous temporal bone, and the tentorium cerebelli is attached like this. And there's a notch in the tentorium cerebelli which passes the midbrain, into the pons and then the medulla, and under the tentorium cerebelli lie the cerebellum. So the posterior cranial fossa is entirely under the tentorium cerebelli. So any lesion above this tentorium cerebelli, any lesion in this region would press the tentorium cerebelli, will press the pons and the cerebellum, will stretch the sixth nerve and cause paralysis. So this lesion is called as supratentorial space occupying lesion, ST-SOL. Okay, so the cavernous sinus you were talking about, and the cavernous sinus has passed the internal carotid artery, entering from the foramen lacerum, becoming the anterior cerebral and the middle cerebral. It has passed the sixth nerve, and the other nerves that pass through it are called as OTOM, oculomotor, trochlear, ophthalmic, maxillary. The oculomotor, trochlear, and ophthalmic, which is fifth A, enter through a fossa, which is the superior orbital fissure, lying just underneath the lesser wing of sphenoid. So anterior clinoid process actually divides the optic foramen and the superior orbital fissure. The superior orbital fissure, we'll rub off something to be able to show it, to be able to write here. So the superior orbital fissure, will pass the third, the fourth, the fifth A, that means ophthalmic, and the sixth nerve. It will pass the superior and the inferior ophthalmic veins, and it will pass the lacrimal branch of meningeal artery and meningeal branch of lacrimal artery. So these are the structures that pass through the superior orbital fissure. Then the next foramen that you see is this one, the foramen rotundum. This is the foramen rotundum. Which passes the maxillary nerve, the fifth B. And then there is the foramen ovale, this one. Here you see the foramen ovale, this one. And this foramen ovale would pass we'll rub this off. The male will pass through ovale. foramen ovale will pass male, M-A-L-E. The mandibular nerve, the fifth C, trigeminal की fifth C branch, the accessory meningeal artery, the lesser superficial petrosal nerve, and imagery vein. Connecting the cavernous sinus to the pterygoid plexus in the infratemporal fossa. So, this male will pass through ovale. And the most important thing that passes through ovale here is the lesser superficial petrosal nerve, which comes from within the petrous bone through the hiatus for the lesser superficial petrosal nerve, which lies here under the trigeminal impression. The nerve coming from here passes into the foramen lacerum, foramen ovale. And the greater superficial will pass into the foramen lacerum, take sympathetic supply from the internal carotid artery, pass through the pterygoid canal into the pterygopalatine fossa, hike onto the maxillary nerve and then the lacrimal branch of the ophthalmic nerve to supply the lacrimal gland. So the greater superficial petrosal nerve becomes the deep petrosal nerve and supplies the lacrimal gland. The lesser superficial petrosal nerve arising from a foramen under the trigeminal ganglion would go into this foramen ovale, will hike onto the mandibular nerve, then the auriculotemporal nerve, and will supply the parotid. So after the foramen ovale, we come to foramen spinosum. Foramen spinosum. It is called as foramen spinosum because the spine of sphenoid lies under it. From this will enter this beautiful maxillary middle meningeal artery which you see here, and it is at the stereon. The junction of the lesser wing of the sphenoid with the calvaria, that this gets ruptured and produces a hematoma, which is extradural, which is outside the dura. Which is outside the dura. I'll make it like this. Outside the dura, and it's a supratentorial space occupying lesion which displaces the brain laterally and also displaces the tentorium cerebelli downwards. But first the lateral displacement, which produces a pupil which is called as the Argyll-Robertson pupil, first irritating the oculomotor nerve of the left side, then paralyzing it, and then affecting the oculomotor nerve of the opposite side and paralyzing it. So the pupil constricts, then dilates on the left side, and then the right side constricts and dilates, and you have a fixed dilated pupil. That means now your patient is almost brain dead. So this is the Argyll-Robertson pupil because of the lateral displacement of the brain. And then finally, if the tentorium cerebelli is starting to depress, then the first thing that will happen is that the abducent nerve will get tight, the lateral rectus will get paralyzed, The person will not be able to deviate the eye to the lateral side, and you will demonstrate it in an unconscious patient by what is called as doll eye movement. So, the foramen that lie in the middle cranial fossa, a superiorbital fissure, foramen rotundum, foramen ovale, foramen spinosum, and two hiatus, one for the lesser superficial petrosal nerve emerging out of the foramen ovale, hiking onto the mandibular and the auriculotemporal, supplying the parotid. The other is the greater superficial petrosal nerve, emerges out of the foramen lacerum, takes sympathetic fibers from the internal carotid artery, becomes the deep petrosal or the median nerve, goes into the pterygopalatine fossa, hikes onto the maxillary nerve, and then the lacrimal branch of the ophthalmic nerve to supply the lacrimal gland. So the greater superficial petrosal and lesser superficial petrosal, if you can tell the course of this in the cranium, you would score very, very high marks in your practical exam. So that means you really know. That means you really know. Okay. Now we come to the posterior cranial fossa. In the posterior cranial fossa, you have the foramen magnum. The foramen magnum. And here is the occipital condyle, which will articulate with the condyle of the atlas and will cause that nodding movement of yes. Now this is the hypoglossal canals too. Through anterior hypoglossal canal emerges the hypoglossal nerve. Then this is the jugular foramen. We'll rub this off. This is the jugular foramen. And the jugular foramen, you see, one of the things that comes out of it is the inferior petrosal sinus. The other thing that comes out of it is this sigmoid sinus, comes like this. And between the three lie between the two lie, this becomes the internal jugular vein. The two become the internal jugular vein, and between the three lies the three nerves. Between the two lie the three nerves, the 9th, 10th, and 11th. The 9th is the glossopharyngeal, the 10th the vagus, and 11th the accessory. So these are the structures that you see in the posterior cranial fossa, and finally you see an internal acoustic meatus here, and in this internal acoustic meatus, the structures that pass through are the seventh nerve. The seventh nerve. We'll rub off some to show you to write this also. So in the internal acoustic meatus, you have the structures passing the seventh nerve, the anterior inferior cerebellar artery enters and comes out of it. It enters and comes out of it. Then you have the ductus endolymphaticus, which supplies the fluid supply in the internal ear, endolymphaticus. And you have the eighth nerve, the vestibulocochlear. So these are the structures that enter the internal acoustic meatus. Now, this in short has covered the skull from inside, and that's on the actual skull.